The systemic steroids that are used are prednisone and methylprednisone. For systemic juvenile arthritis, where you need steroids at a higher dose, some people have come up with pulsing these children on a monthly basis, and they find that you might have less side effects when you do that. Try and keep the dose less than 0.50 milligram per kilogram in case of oral prednisone. There's an ongoing study which is trying to see whether starting children on steroids at the time of initiating therapy with DMARDs will retard the progression or slow the onset of erosions as it has been seen to be done in adults. We don't have the results as yet. I just want to mention that there is a concern about intra-articular injections, whether repeat injections might damage the joint. So the recommendations generally are that do not inject the same joint before 6 months. Try not to inject the same joint more than 3 times. And there is a worry a lot of people have about osteonecrosis. If you inject the joint, that doesn't seem to be true. Methotrexate, cornerstone of therapy for children with juvenile arthritis. Please increase the dose. It's very safe if you monitor it well. It has a very good response, particularly used for polyarticular, used for systemics, used for those oligoarticular patients who after 6 months become polyarticular, and doses recommended 10 to 15 milligrams per meter square. However, people have gone up even more than that, given as much as 20 milligrams per meter square. It takes at least a few weeks, 8 weeks, before it shows any benefits. Just want to mention there is an enzyme, MTHFR status for these 2 mutations, which is checked in the US or other places where this is available, and people who have mutations at these sites, the children will not respond and have toxic effects, and generally pediatric rheumatologists will check the children before starting them. We don't have that, so start with a low dose, check the counts, and then increase. Sulfasalazine is used, it's available. I just want to mention it has a good place in ERA, with peripheral arthritis and psoriatic arthritis. In children also who have oligoarthritis. However, it does not, it can't really have erosive disease. It does not prevent chronic joint damage, so it should not be used in aggressive disease. Cyclosporin, you can use that specifically in macrophage activation syndrome, which I'll talk about, and it is also effective in some children who don't respond to anything with dactylitis. Meflunomide, not FDA approved. I've just given the doses because these are difficult to find otherwise. However, it works very well, especially in polyarticular juveniles who are not responding to methotrexate or have toxic effects due to that. Biologics, Enzyme, FDA approved. Cost is a limiting factor. I think with us also the fact that we are endemic for tuberculosis is also a limiting factor. We really worry about putting children on enzyme before doing that. However, it works very well, and we do have one child at least who's a systemic juvenile, and she has responded to it. Infliximab is not FDA approved, works well for uveitis. Orange is not available here, but it has been FDA approved, and it has shown very good response, and it is safer in terms of risk of tuberculosis. Tocilizumab, it's investigation for children and adolescents, but it has a very definite place in systemic juvenile arthritis. Works very well. There are a lot of studies, and especially coming out from Japan. I've just mentioned adalimumab. We don't have that. Dr. Abid Sadiki had mentioned rituximab having been given in his experience to juvenile arthritis. Actually, there is some published data, limited experience, but it has been shown to have some role in adolescents who are RS-positive disease and who are not responding to anything else. Abatacept, again approved for the treatment of JRA. I'm just going to touch upon what to do with systemic juvenile arthritis. Children are very sick sometimes. They don't respond to anything. They don't respond even to high-dose steroids in the sense that they don't become symptom-free. The fever still persists. Their arthritis still persists. So tocilizumab is very effective in this group, and we are happy to know that it is at least available on request, and for people who can afford it, we have an option. Thalidomide. I wish we had this in Pakistan. It suppresses both IL-1 and IL-6, which seem to be the mediators, the cytokines that are involved in systemic juvenile arthritis. It is reasonably economical, and it works very well in systemic juvenile arthritis. Some special issues that relate to children, like because this is a growing skeleton, so you have problems that affect differently different areas in children than you do in adults, particularly the cervical spine and the TMJ. They have midline discrepancies. You can have growth retardation, contractures, and as I mentioned, anterior uveitis. These are some of my children. If you notice, please always ask the child to extend the neck, because if they're looking straight at you, you may not even tell that she has severe limitation. Such children especially you need to be careful when they go in for surgery. The anesthetist has to evaluate them because when they put in the endotracheal, this could be a problem. If you have TMJ involved, if you can tell